We will enter into the next half hour, to the discussion period. Now it's up to you to come to the microphone. For specific questions you may have to some of our presenters this afternoon, and then also it is possible to, if you have larger comments that this day has raised for you, just to come forward now. And please use the microphone. There's one on this side and on the other side, please, for courtesy for people who are on the conference. Yes?
Yeah, I have a question to Ross. In terms of stigma reduction and intervention, what is the target? Are we aiming at zero stigma? Is that at all possible? And if it's not possible, what is acceptable?
Okay.
No, we're not aiming for total elimination, even though that is often, well, no, let me, depends on who you address the question to and who we are. Certainly there are initiatives that, including some in Canada, that have taken as their formal goal the elimination of stigma of mental illness. I think that's being very overly optimistic. What is an acceptable goal? I personally think of the acceptable goal very much at the behavioral level. And for me, the behavioral level goal would be, I would be delighted with any interventions that show significant decreases in actual or significant improvements in actual behavior towards individuals with mental illness at a follow-up of 6 months. I think in operational terms that would be quite an accomplishment. I am unaware of any intervention that has ever been evaluated that has shown that.
Thank you very much for the wonderful day and the wonderful conference. I have, if it is okay, two questions. One is to Marita. I was wondering about the population that you looked at the HPA access, if many of them were under 18, because the HPA access is not stabilized before the age of 18, and that may be a confounding factor, especially when you compare, when you don't have the same case that you're comparing with the person themselves, but you compare as numbers, and that is like one of the things that I was wondering. And my second question is for Professor Ross. I don't know if I should.
We'll start with the answer to this one, please.
So as for the ultra-high risk group, when I talked about the response to the psychosocial stress test, this was an age and gender matched group. So they all had the same age and gender. So there was no difference. So I don't think that age effect on the HPA axis could explain the result. This is what, and why we did this.
Versus female, because there are also the female hormones once they hit puberty that also affect the hormonal response. And in terms of the hyporeactivity, obviously there are the theories for epigenetics about trauma and the effect of chronic trauma. I was just wondering, because I know that, for example, in depression it is very difficult to do dexamethasone suppression test under 18 because we don't have that stability. So I'm just wondering if that had anything to do. Yeah.
I wouldn't know. So beyond the age and gender matching, I would not know if there's any factors. The mean age is around 20.
Okay.
Yeah.
Okay. Thank you. My other question was actually a comment and a question together. One of the greatest difficulties that we have around stigma come from families who have had experience with psychosis. And for example, parents who had a sibling or grew up with a psychotic sibling. and in fact, treated 20, 30 years ago with not very good results. And then there is a sort of internalized stigma within the family, let alone within the individual, when you have a young adolescent that presents with a psychotic episode. And we found that these families are extremely challenging because you have to convince them twice that there may be, good results, and you have to put a lot of effort on that. I was wondering if in any of the stigma studies, that question of families that have already vulnerability, not just the vulnerability biologically, but also have had this experience, if that has been addressed at all. And what is your experience on that issue?
I may change my mind, and if I do, I will get back to you over the next day or two. I am unaware of, I'm having trouble thinking of any studies, formal studies, that have actually addressed that in terms of the question you're asking. I think that, yes, does it have, is that consistent with my experience? Yes, certainly. That is often a factor which interferes with, I think, I can think of cases where that's been a factor that's interfered with people coming to treatment. It more or less just hoping that it will go away because it is much too much difficulty for the family to deal with it. How does one, well, it's a multifaceted issue of the contributors to that. I think, again, there are the sort of the factors which contribute to the shame feeling. We can think of this in terms of contributors to that shame, in the past having been factors around assumptions that maybe the families in some way contributed to the onset of the disorder or things of that sort. But my impression is that really the shame doesn't seem to be that much less, even if you think of it in biological or inheritance of a genetic risk. I think that for one of the most important things we can do, and it's much more difficult probably for a family that has been through the experience 30 years ago, but two things that I think can be helpful, and a couple of us were discussing this earlier this afternoon. One is that in the past, in terms of the reaction people have gotten from clinical services, it has been one which really has sort of led to humiliation of the family. And so I think that anything we can do as clinicians to minimize that would be very helpful. Second is the entire issue of hope. So we will say to families, well, we know much more now than we did 30 years ago, and so we can probably get a much better outcome. We know that's not going to be true for everyone. But I think as much as we can indicate and show stories, individuals, narratives that show we can get much better outcomes. And I think narratives are probably going to turn out to be far more effective in this regard than data charts. So to the extent that we can actually show individuals, refer to individuals, indicate individuals who've had very, very good outcomes, that would help.
I just have a question for Max. Max, what do you think is the underlying reason for the neglect of the whole idea of affect being included in psychosis? I mean, the very fact that we refer to them as non-affective and affective psychosis, I mean, and yet we know during the prodromal period, most people go through a depression. Historically, do you think there is a reason? You know what I'm trying to get at.
I think you should answer the question. Okay, well, I suppose it all goes back to Kraepelin, doesn't it? Kraepelin made this fundamental distinction between schizophrenia, or dementia precox, and manic depression, and that building block of psychiatry is still with us. It's still taught, the evidence that they are fundamentally different disorders is just slowly eroding. And there's been a lot of really good molecular genetics work done by one of my colleagues, Nick Craddock, that great study in The Lancet a few years ago, and others about those disorders having common genetic background, and a risk for one in the family does pose a risk for the other. There is, repeating what I was saying earlier, that although we have these profound distinctions, in terms of symptoms, in terms of any kind of etiology, in terms of prognosis, the validity of that distinction just does not hold. And I don't quite know why we're carrying on teaching it, but I think it's one of those things we've just got to divest ourselves of, I think. What about you? What do you think?
I'm wondering how much it has to do with the fact that bipolar disorder has a spectrum with and without psychosis, and bipolar disorder is relatively, at least has some variability in social class that, or at least it's believed that upper middle classes, bipolar disorder people are more educated, and therefore it has to be separated from.
Right.
And the second point I wonder is how much, Freud said that people with schizophrenia have no capacity to relate, and therefore, the psychotic patients could not really enter into a kind of a true psychotherapeutic process. But now we look at how many years later that psychotherapy, at the end of the day, in a very different form, is really the most effective way of engaging and treating patients. And ironically, it was an analyst who brought this whole prodromal thing into our attention, was Harry Stack Sullivan, that really started talking about the period of prodromal, that how we can still engage patients in that and actually see them through this period. So I wondered how much of the social engineering has kind of gone into our classification system.
Yeah, I suppose it is. Yeah, it's interesting sociological analysis, Ashok. Yes, that it's a bit like autism is quite a middle-class diagnosis, isn't it? It sort of grew in the 70s, and people prefer that to learning difficulty, don't they? So I suppose there is some sociological basis to what people are prepared to accept. And I guess maybe diagnoses that clinicians are prepared to give out. But I think in clinical psychiatry, I think the real issue continues to be the fundamental teachings, that the building blocks of psychiatry really just need to be rewritten, don't they? In the last 10 years, I was saying earlier, there's been such a transformation, isn't there, in understanding that these separate silos are actually probably linked. I remember that great piece of work. You remember Ian Brockington? He did that. He's a guy who did a lot of work on taxonomy of mental disorders, and assembled all the psychosis, about 10,000 patients, and measured all the symptoms from bipolar disorder right through to classical schizophrenia. And he used cluster analysis to see whether he could replicate the clinical diagnoses, whether they were clearly separable statistically. And all he found was one long continuum. And that's what we're finding now, isn't it, in the prodrome, that there's no distinct prodrome for schizophrenia from bipolar disorder. These things develop a little bit over a period of time. So personally, I think there's the next science, it's the emerging science, is that developmental aspects of mental disorder and why they differentiate. Perhaps Pat, is he still here? No, I think he's gone, hasn't he? He put this beautifully. He's thought this out very neatly in the idea of the pluriopotential nature of mental health problems, that, in adolescence it's a big swamp of mental disorder, and why people go along different paths is not preordained. It's a very active process that is, differentiating people, and individuals who in one setting could develop schizophrenia, in others might well escape it and be protective factors. I think that developmental phase is really the most interesting phase. But I can only agree with you that we really just need to change our thinking fundamentally. Yeah.
and then present your results. Because
Yeah.
if you don't believe these results, they all have psychotic disorders.
Yeah, exactly. So I've got sorry, I'm.
Just repeat what he said.
So, sorry, Ashok was saying, was getting exasperated with journals who continue to ask that you be clear about your diagnosis, or that if you've got a mixed group of individuals, that you exclude one group in order to have greater clarity about the individuals that you are under investigation. And, absolutely, I agree. I mean, most of the risk factors are transdiagnostic. Most of the interventions are transdiagnostic, and probably most of the etiology as well, in a lot of respects, is also transdiagnostic. So how long this will last, I really don't know. But I was looking in a manual of a new textbook of psychiatry, and the distinctions are still taught. Well, the DSM-5, as Pat was saying earlier, has come up with even more silos and distinctions. It's just crazy. It just doesn't correspond to the people I've seen, anyway. Sorry, I was off on one there. So.
For you, Professor Birchwood, and after to Professor Norman, I'd like to know the neglect. How did the parental neglect? How did you measure that? Was it just self-report, or?
Yeah. How do I measure parental neglect? Well, first of all, these are all retrospective, and it's entirely from the point of view of the individual who experiences it.
Okay.
So it's a self-report. It's usually self-report. It's retrospective, and it's entirely judged by the individual who receives it. So it's entirely, sort of quasi-objective, I suppose, but it's the best that we can get.
And I mean, is it just like a straight question about if
No, it's the CTQ, the Childhood Trauma Questionnaire. Okay. You Google that. It's a very well validated, widely used measure. Okay. And while its ultimate validity is very difficult to assess because of the retrospective nature of it, it does enter into all sorts of lawful relationships that you would expect. People who score highly on it have poor outcomes in all sorts of disorders. Okay. So the Childhood Trauma Questionnaire, Bernstein and something or other.
Thank you. And did you look at other trauma like bullying or psychological abuse? Or?
In this study, no. But you're absolutely right. There's been very good evidence that the experience of bullying, particularly in school, in the school context, is related to an increased risk for psychotic experiences. That's very well established now. Some very good, by the way, meta-analyses of the role of abuse and neglect as risk factors for psychosis in the last year in Schizophrenia Bulletin. Mm-hmm. And if you are in any doubt that they are genuine risk factors, read those reviews. Varese, Bentall and colleagues.
Thank you.
Hi. Are you finished? Or?
I was just wondering this paradoxical effect of anti-stigma campaigns. Is that seen also in other fields? Like, for example, now they're making a lot of big campaigns about bullying at school and things like that. Do you know about like that paradoxical effect also in other fields and mental illness?
No, I don't. I'm not quite sure which paradoxical effect we're talking about here. For instance, the biogenic explanation, or the.
Well, I mean the fact of doing anti-stigma campaigns increases the people's fear of mental illness.
Yes. No. I'm not aware of that in any other field. To the extent that it might, I think there are a number of reasons why you can get paradoxical effects, and to the extent that we've gotten them, I think there is the normative possibility. We are telling people things about mental illness, whatever the validity of them, they are increasing their concern and their concerns around danger, unpredictability, and so on and so forth. I will take the opportunity to say that one thing I'm a little uncertain about with regard to these paradoxical effects, for instance, associated with biogenic explanations, is whether they really will occur across disorders or whether they are particular for disorders where part of the automatic associations are ones of danger. So I would like to see the study, I would like to do the study, I may yet do the study, wherein we look at whether the effects of a biological explanation are the same when you're dealing, for instance, with schizophrenia versus dealing with depression or anxiety disorder. I think there may be a moderator effect in there. Max.
Thank you. I want to just say what a wonderful day it's been, and thank. Oh, is there more? Okay.
No. Stay there.
Don't go away. It's just this comment about the paradoxical effect of exposure. We did a study recently in schools, and we did a lot of education about mental ill health and the likelihood, and particularly as it affects young people. And we had two groups, one where we just did that kind of usual type of stuff, and another group where we had some service users delivering that information. At the end of the day, they revealed themselves as having mental health problems. And we thought this was a great maneuver to increase contact. It had the very reverse effect, that immediately afterwards, and 6 months later, those who had the contact and exposure with these people, they developed a relationship with them, their stigma increased massively. Very interesting. And it got us thinking about what on earth is going on here. And one of the ideas we came up with in the UK, I'm sure the same here, 20 years ago, homosexuality was an immensely stigmatizing disposition. Immensely stigmatizing, and it's changed dramatically. There's now, gay marriage has just gone through our UK House of Parliament, and there are lots of very positive role models and so on. Lots to do, but it's changed dramatically. In mental illness, it's not changed at all. And I just wonder whether it's something about that this could be me. It was very interesting that a lot of these young kids in school were themselves about, as you would expect, in line with most of the surveys, 30-40% of them had mental health problems now or in the past. And there is something to do about fear that it may be me, and that this is something that I might have to deal with at some point. It's the personalized nature of it, I think, and the fact that it could affect individuals that I think has something to do with the paradoxical effect. I don't know what you think.
A whole lot of other things, but maybe we'll let the lady have a question.
Thanks. I wanted to just make a comment and a question. The comment is about the question regarding how to help families and deal with families. And I'll just put in a little plug for some research that I did with the National Alliance on Mental Illness in the U.S., where we found that family members who participated in the NAMI, National Alliance on Mental Illness, family-to-family education program, had considerably reduced, enhanced hope, empowerment, perceived family functioning, knowledge, and a variety of other things. And while so one suggestion, one thought would be to encourage families who have experienced mental illness and, say, in a sibling, to connect with other family members. Now that may not always work, because there can be it could go the other way. But in your community, if you can find family members to do some outreach and connection, that could be very helpful. The question that I had was really for many of the speakers or whoever was interested to just address the issue of substance use in terms of the social anxiety. I was interested in terms of recovery story and recovery self-concept, and also in terms of stigma, co-occurring substance use. Well, I thought it was striking, given how common it is that there was very little spoken of today, and I thought that we have to push that field much further, and whether it arose, for example, in people's recovery stories or in the social anxiety.
The one comment is that substance misuse and psychosis is a big problem. But I just wonder whether there's a bit of a an illusion that somehow the reason why they are comorbid is something to do with the psychosis. We did, you talk about this tomorrow, but the work that we've done, I had a PhD student looking at the reasons why individuals started using cannabis and compared those who are, with first episode with those who are just cannabis users who are adolescents. And the reasons were exactly the same. And the reasons why they started, increased, and stopped were exactly the same. So sometimes I think we're just kind of always looking for reasons to do with, abnormality and mental ill health rather than just ordinary reasons to do with context that individuals are living in and their developmental stage. But just a thought.
Okay, so Dr. Mala, stay tuned for tomorrow because you'll have more answers to this issue of substance. Yes, Dr. Montreal?
So I had a question for Dr. Birchwood. In our sample, what we had measured, despite there was a significant drop in the social anxiety levels, it seems that the cutoff scores, the significant cutoff scores, our samples seem to still score above the cutoff scores, for example, the CIAS or the SPIN or the BSPS, which sort of got us to think whether there were differences between psychotic, socially anxious from non-psychotic, socially anxious, whether the scales were limited in terms of whether they were measuring the right things. So I wonder what your experience with the samples that you've worked with, if it's reflected similar results, or what's your view on that?
Can I just ask a question? So, did everyone remain above the threshold, or was there variation?
There were variations, but
okay.
What we were observing is that there was, although when
Sure.
we would put it into our SPSS, there would be a significant reduction.
Yeah.
Let's say on the CIAS, the cutoff score was 18.
Sure.
We still had some patients that were scoring above that cutoff score, which sort of brought us to think, well, because in that sense, you would be able to say, well, they're still clinically, according to that scale,
Sure.
they would still be socially anxious, but the qualitative response didn't reflect that. So we got to think whether the scales were maybe not adapted for a psychotic population or people that suffered psychosis with comorbid social anxiety. And I don't know what your experience with that was.
Well, my first reaction is that even if you get a score below the threshold, many of those individuals will still have experiences of social anxiety. And, with these interventions, probably because these experiences are fairly long-standing, it's going to take quite a lot to shift people really, really profoundly. I mean, your results are fantastic. I mean, congratulations. They look really, really encouraging. I was going to ask you a question, actually, if I could just turn the tables. I mean, you did speak after all, so it is allowed. So I'm just intrigued. When you said, did many people drop below the threshold? The question that immediately came to my mind is, was the intervention... how much did it follow the Clark and Wells paradigm intervention for CBT, for social anxiety disorder? Because the effect size of that is about 0.5, 0.6, and I just wondered whether how much it departed from that.
Well, actually, the model that we proposed was largely based on that, to be honest with you. I guess what we did integrate to that model was really the notion of, dysfunctional thoughts, shame of illness, that we sort of incorporated in there. But to be honest with you, I mean, it's a proven model that's been used widely with the non-psychotic population. So our model stems from that.
And therefore, does it follow we need to adapt the model further? I mean, I just wonder whether some of the...
Well, that's my question, and that brings me to the scale, really.
I'm asking you a question.
Because we're bouncing questions back, but that's really what it brings me down to, because you were mentioning before there's not that many differences, but another difference that we noticed... But another difference that we noticed as well when we were doing the SCID, for example, the subscale of the social phobia, is that compared to people that have not suffered from an episode of psychosis, is that the criteria where they ask, do you feel that your experience is very different or catastrophic or largely exceeding that of others? Most socially anxious that have not experienced psychosis would say, yes, I feel that, I'm reacting way more seriously than others. But for some reason, a lot of our I guess, our participants were not really noticing that difference. For them, they were as others. They were not reacting as much as others. So
right.
I'm wondering if, again, that's another difference between samples, between psychosis and non.
It's all in the content, isn't it?
Yeah.
It's all in the content. What it is that people are afraid of being evaluated for.
Yeah.
In our studies, it's partly, people will see me anxious and think I'm stupid, all that kind of stuff. But there's also the issue of concealment. If I talk to other people and get to know them, they'll find out this terrible secret about me. And that will have enormous implications for my social status and so on. So, that's why I was intrigued whether you directly confronted that fear that a lot of people had, and it impinges directly on the stigma issue. And I think that's probably, my guess is that standard Clark and Wells intervention, the effect size, is probably not going to be as great with the psychotic group because the content and the themes are slightly different. The form is the same, but the content. Anyway, we can talk some more.
Yeah.
Okay, thank you.
Okay, there's a question. Okay, so I can take very rapid questions, but maybe they cannot be answered. So a question and comment, please.
Comment or a fear, I don't know what is it. It's more for Mr. Birchwood. It's about okay. It's related to the social anxiety disorder. What about the new generation, which is really overused the social network as Facebook and Twitter, who are more isolated, and I feel that they are in a new world where it's more. You think that you have a lot of friends, but in real life, it's not really the case. Do you think that could increase the isolation and social the anxiety disorder, and can I have an impact on the psychosis?
Okay. And one quick answer.
I'm under threat of death here. It's a very good question. It's a PhD question, and I'm very happy to supervise you. That would be a really, really interesting question. I don't know. I would think so. Interestingly, our social anxiety group that I was talking about, guess how I recruited them? Through the Social Anxiety Disorders website.
Oh. Okay.
So the internet is a fantastic coping strategy for dealing with social anxiety, and it has benefits, but also, as you were suggesting, maybe some drawbacks.
Okay. Thank you.
I could go on, but
okay. Any comment, Dr. Stipp?
A very short one. We know that stigma is difficult to change, and that it is present in every general population, clinical population, GP, etc. But we are very interested by the negative aspect of the stigma. But do you think there is positive aspect in the stigmatization, and if it's present, what could be the advantage to study the positive aspect of a stigmatization in a culture or in a society?
Well, I may be taking it in a different direction than you had intended. There may well be positive aspects to the stigmatized group. There certainly are positive aspects. There certainly are functions that are being served to the population as a whole by engaging in stigmatization, which we didn't get a chance to talk about. But yes, it exists and it's serving functions. It simplifies things. It is seen as protecting people. It is seen as justifying, in some cases, justifying exploitation and so on and so forth. So yes, it is serving functions. There are reasons for the stigma to exist. And I think that we have to recognize those functions and address those functions in any efforts we're making to reduce the stigma. And I will say, just seeing I'm up here and I got the chance, that Max's analogy to the change that has occurred in terms of reactions to people on the basis of sexual orientation is fascinating. And we've played with this a lot, and we've worked it through. We've come to slightly different conclusions as to what the difference is between the two circumstances. But it's fascinating to watch that change, because I think if you look at it, what's been responsible for that change is a greater openness, which sort of keeps being reinforced as the stigma goes down, but a greater openness. The fact that many individuals have we've gone through the period where many individuals have said, many talented, productive, attractive individuals have said, this is me, this is what I am, and look at me. I've done incredible things, and I am no danger to you or any harm to you. I live next door to you, and so on and so forth. And I think that's one of and then it now has gotten to the point where clearly the norm is quite contrary to what the norm was earlier, in terms of, while at one point 20 years ago it was quite acceptable to ostracize people on the basis of their sexual orientation, now the norm has changed so that it is no longer acceptable. That's why I keep coming back to the notion, whilst those examples of very, very famous attractive individuals are not as readily available in the case of psychotic disorders, there are still many positive attributes of individuals who've recovered from psychotic disorders, and some remarkable recoveries that could be highlighted, and I think would start to bring about not the same magnitude, but at least somewhat of a parallel change in terms of people's openness to recognizing that people with psychotic disorders are not all dangerous, are not all a threat, and so on and so forth.
I will pass the microphone to Dr. Mala, who will explain to you where to go for the poster session and the wine and cheese. I would like now to take the opportunity and with you to thank our conference presenters this afternoon, Professor Birchwood, Professor Nolan, Madame Wendell, Dr. Montreuil, et Dr. Prusner. Thank you very much.